Hi, how are you? It's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. It's me, Dr. Muhammad, and we are talking about one topic, very important topic. And I want to talk about this topic, such as the pineal gland tumor, pineal region tumor, and I want to talk about generally about as a lecture, and then we will take one case for the analogy, and then we will talk, and I will try to explain as much as for the best of my knowledge, and maybe it will helpful for all of us. Thank you so much. So now then I want to present like that. There is a tumors of the pineal region are rare and account for 1% of the all intracranial tumors in adult and up to the 8% in children. 1% of all cranial and 8% of children. And the multiple pathologies are associated with this region due to the variety of the cell in the gland and the structure located adjacent to the gland. And the tumors of the pineal region are classified into these arising from the spinal parenchyma, germ cell neoplasm, metastatic form, other organs, and the lesion arising from the adjacent structure. This activity reviews the evaluation and the management of the spinal gland tumor and explains the role of the interprofessional team in evaluating and treating the patient with this condition, and we can identify the etiology of the spinal gland tumors, and we can evaluate the spinal gland tumor, and we can learn how to manage the spinal gland tumor here. As I mentioned before, the spinal gland tumor is a small endocrine gland, 10 to 14 millimeter, located in the midline of the brain at the superior aspect of the posterior border of the third ventricle in the coronal view, and the gland is located below the splenium of the corpus callosum and above and the posterior to the tectum of the midbrain, and its principal function is to secrete the hormone melatonin and receive information from the environment about the light dark cycle to the feedback and the central nervous system. The principal cell of the pineal gland are the, we can say, pinealocytes or the pineal parenchymal cells, and the multiple pathologies are associated with this region due to the variety of the cells and structures located adjacent to the spinal gland. And the tumor of the pineal gland are classified into those arising from the spinal parenchyma, germ cell tumor, and the lesion arising from the adjacent structure, and other lesions adjacent to the gland are astrocytomas, oligodendrogliomas, or the glial cell tumors, or the, we can say, the glial cysts or the pineal cysts, meningiomas, araconite cysts, ependymomas, and chemodectomas, epidermoid, dermoid, metastasis, aneurysm of the vein of the Galen, and arteriovenous malformation, and we can say the cystic sarcosis, and so this review all discuss those tumors which arise from the gland proper and the germ cell tumors. Importantly, we have to understand this anatomical structure adjacent to the spinal gland tumor or spinal gland. So here, the anteriorly, the third ventricle is present anteriorly to the pineal gland, and anterosuperiorly, you can say, the habenular nuclei, and we can say the superiorly internal cerebral vein, the vein of Galen posteriorly, and the stria medullaris and the splenium of the corpus callosum, and the valium, we can say the valium interpositum. Posterior inferiorly superior cerebellar cistern, and inferiorly superior colliculi of the midbrain, and anterior inferiorly posterior commissure. And here I want to show you a few pictures regarding the anatomy of the pineal region, or we can say the pineal gland. So you can see here, this is a pineal gland, and you can see anteriorly there is the third ventricle, and a third ventricle is anterior to the we can say the the pineal gland, and posteriorly, as I mentioned before, posteriorly there is the posterior cerebellar and cistern, and laterally you can appreciate there are the superior colliculi of the midbrain, and you can see here the superiorly there is the superior sagittal sinus, and if we go there, then the superior and sagittal vein, a cerebral vein, and the vein and the great vein of the gland, and more posterior commissure, and the splenium. So these are the structure you can understand by anatomically a little bit. Then now I try to explain you here little anatomy, a very good picture in front of me, and you can see you can see the pineal gland here. Sorry, and this is here. This is the pineal gland, and you can see the superiorly, and you can appreciate there is a corpus callosum part, or the volume or interpositum, and anteriorly there is a third ventricle, and inferiorly there is a midbrain or the superior colliculus of the midbrain. Infero anteriorly you can find, and the third ventricle anteriorly, and posteriorly there is a cerebellar cistern and superior cerebellar cisterns, and so this is the anatomy. So how much central pineal gland could be, you can understand with this picture. And now, so you understand there the anteriorly third ventricle, which is called the pineal recess, and the anterior superiorly that we can say there is a hemilunar nuclei, and superiorly internal cerebral vein or the vein of Galen, posteriorly an stria medullaris, and splenum of the corpus callosum, and the valium interpositum. So these are the superior structure, the valium of corpus, splenum of the corpus callosum, valium interpositum, then vein of the Galen, stria medullaris, internal cerebral vein. Posterior inferiorly, if you see the superior cerebral cistern, and more inferiorly you can see the superior colliculi of the midbrain, and the anterior inferiorly there is the posterior commissure. And definitely the things are coming, what are the causes or the etiology of the spinal gland tumor is based on the histopathological classification. So I want to tell you the pineal parenchymal tumor, pineocytoma, pineal parenchymal tumor with intermediate differentiation, pineoblastoma, and papillary tumor of the pineal region. These are the papillary, we can say the pineal parenchymal tumors, such as the pineocytoma, pineal parenchymal tumor with the intermediate differentiation, or the pineoblastoma, and the papillary tumor of the pineal region. If we can see the germ cell tumors here, the germinomatous germ cell tumor, such as the pineal germinoma, or the neurogerminomatous germ cell tumor, such as the choriocarcinoma or embryonal carcinoma. Yolk sac tumor, endodermal sinus tract tumor, or the immature teratoma, or the mature teratoma. The tumor of the pineal gland are rare and account for 1% of all intracranial tumors in adults. However, they account for up to 8% in children, and due to the diversity of the tumors in this area. And the characteristic and epidemiology vary greatly, will describe each according to the WHO 2016 classification. The tumor of the spinal area are rare and account for the only 1% of the all cranial tumors in adult, and however they account for up to 8% in children. So due to the diversity of tumor in this area, and the characteristic and the epidemiology vary greatly, will describe each according to the WHO 2016 classification. And the pineocytoma can be seen at any age but mostly occur in adults for the 20 to 60 years of age, and the pineocytomas are more frequently encountered in female, and they account for 14 to 30% of the pineal parenchymal tumor and are mature, well differentiated tumors. So, the pineal parenchymal tumor with the intermediate differentiation, these tumors are mainly seen in middle aged adults from 20 to 70 years of the age, and they have a slight female preference and similar to that of the pineocytomas, and they account for 20 to 62% of the pineal parenchymal tumor and making them one of the most common intrinsic spinal tumors. Actually, here very important. I don't want to repeat it, but I want to mention few important things in front of you, such as the tumor of the pineal area are rare, and you know that. So the pineocytoma can be seen at any age, but mostly occur in adults and from 20 to 60 years of age, and the pineocytomas are more frequently encountered in the females, and the male female ratio you can consider, if there is a 0.6% in the male, then one is the female. So two female, or you can say two female is to one male is, I think, a more appropriate thing. But they account for the 14 to 30% of the pineal parenchymal tumor and mature well differentiated tumor. It's a well differentiated and mature tumor, and it is called according to the WHO grade 1. But the grade 2 tumors, these tumors mainly seen in the middle age adults from the 20 to 70 years of age, almost the same age, and they have a slight female preference. The same way the WHO grade 1 pineocytoma, this pineal parenchymal tumor with intermediate differentiated, also the same things, and as mentioned before, the more preference in the female as compared to the male, and they account for the 20 to 62%. Means that one is a 14 to 30%, and this is a 20 to 62% of the pineal parenchymal tumor, making them one of the most common intrinsic pineal tumor. And this WHO grade considered 2 or 3, means if more undifferentiated, if less undifferentiated, then definitely it will come in grade 2. If more undifferentiated, then it will go definitely on the phase 3. But more differentiation is a lesser grade, higher undifferentiation or less differentiation, there is a higher grade. So the third type I want to mention here is the papillary tumor of the pineal region. This papillary tumor have the broadest range of the age, and it is from the 1 year to the 70 year of age, means it almost any age group, and most often it happens in the mid age, and there is a no gender preference. It can do any, and it will also consider in the grade 2 and grade 3 or grade 2 or grade 3. So this pineal parenchymal tumor with intermediate differentiation and the papillary tumor of the pineal region, both are coming in the grade 2 or grade 3, but the pineocytoma will come in the grade 1. So the pineoblastoma is the most aggressive pineal parenchymal tumor, and they account for 24 to 50% of the all pineal parenchymal tumor, and they have a slight female predilection more. You can say, maybe if you can see them as, for example, it means there is the 2 male and is to 3 females, and they are typically seen in the young children and a patient with the hereditary bilateral retinoblastoma are prone to suprasellar or pineal neuroblastoma tumor, and this condition called the trilobar retinoblastoma seen in up to 5% of the pineoblastomas. So this is a very understandable, this trilobar retinoblastoma when involving the both eyes, retinoblastoma, and simultaneous the pineal gland tumor. and it is considered the most aggressive tumor, and this considered definitely the WHO grade 4. This is pineoblastoma. Then comes the germinoma. It accounts for the 50% of the pineal parenchymal tumor. It is much more common in male, means 13:1 means germinoma, a significant predominance in the predominance for the male. 13:1 means the 13 male has been affected and 1 female. So the most are 20 year or younger at the time of the evaluation, and the commonly diagnosed with the CSF cerebrospinal fluid tumor marker, and they have elevated placental alkaline phosphatase and beta human chorionic gonadotropin, we can see beta HCG, and this considered also WHO classification grade 4 or maybe malignant, or we can say this is a malignant tumor. Then coming the choriocarcinoma. This choriocarcinoma, the uncommon tumor, is a very, very uncommon tumor among the pineal region, for the 5% of the pineal region mass and 10% of intracranial germ cell tumor, and they can found in the pineal and suprasellar region, and they have increased CSF and the plasma beta HCG, and WHO classification is malignant considered here. And then will come the embryonal carcinoma. This is also uncommon tumor which account for less than 5% of the pineal region masses and 10% of intracranial germ cell tumor, has and propensity for metastasis, and the mixed germ cell tumor can have a component of the embryonal carcinoma which confer a worse prognosis, and elevated tumor marker can be seen in CSF such as the alpha fetoprotein. WHO classification come for the embryonal germ cell tumor also. The malignant, as I mentioned, is a mixed germ cell tumor and can have a component of the embryonal carcinoma, and which confer a worse prognosis, and this is the elevated tumor marker can be seen in the CSF, and it is the alpha fetoprotein. So these marker definitely you can understand, but as you know that the choriocarcinoma beta HCG and the germinoma beta HCG as well as the alkaline phosphatase, and here the embryonal carcinoma which is alpha fetoprotein and beta HCG. So in all three the beta HCG is common, but for embryonal carcinoma alpha fetoprotein more specific, and the germinoma the alkaline phosphatase is more specific. So then we will proceed for one more type, and which is important to understand, is the yolk sac carcinoma. And the pineal yolk sac tumors are a rare manifestation of extragonadal yolk sac tumor, and they make one of the smallest fraction of the intracranial germ cell tumor, and they sometimes have an association with trisomy of 21, or which is the Down syndrome, and CSF studies show elevated level of the AFP but are non-diagnostic, and the WHO classification coming again for that the malignant. So here all malignant tumors I presented in front of you, the yolk sac germ cell endodermal tumor, the pineal yolk sac tumor are the rare manifestation of the extragonadal yolk sac tumor, and they make one of the smallest fraction of the intracranial germ cell tumor, and they sometimes have association with trisomy 21 Down syndrome, and shows the elevated level of the alpha fetoprotein but are non-diagnostic. So immature, mature teratoma and uncommon tumor, however, it is the most common fetal intracranial neoplasm, and 26 to 50% of the fetal brain tumor, and can be mature or immature, which generally change to the prognosis, and gross total resection of the mature teratoma is considered curative. WHO classification here, there is a malignant, mature WHO classification, we can say benign, but the pineal gland forms during the seventh week of the gestation. In human, the principal function of the pineal gland is the production of the melatonin, which modulates the sleep pattern, and it is also associated with puberty and reproductive functions. Tumors of the pineal gland region are diverse in origin due to the proximity of the multiple anatomical structures, and the pineal gland is commonplace for the sequestration of embryonic germ cell tumor. Thus, the germ cell tumor are among the most common pathologies found in this region. So the germ cell tumor typically occur sporadically, and however there is an association with Klinefelter syndrome or the Down syndrome or the neurofibromatosis type 1. So the germ cell tumor typically occur, as I mentioned. The pathophysiology is very important to understand here. The pineal gland now forms during the seventh week of the gestation, and in human the principal function of the pineal gland is the production of the melatonin, which modulates the sleep pattern, and it is also associated with puberty and reproductive function. So tumor of the pineal region are diverse in origin due to the proximity of the multiple anatomical structure, and the pineal gland in compliance for the sequestration of embryonic germ cell tumor. Thus, germ cell tumor are among the most common pathologies found in this area. And germ cell tumor typically occur sporadically, however, there is an association with the Klinefelter syndrome, Down syndrome, and neurofibromatosis type 1. So, the pineal region tumor are generally classified as the pineal parenchymal tumors, germ cell tumors, adjacent cell tumors, and the metastasis. Here, regarding the pathophysiology, I want to mention few things because it's important to. I want to, maybe you feel repetition, but I don't think it's a repetition. But I want to express you few things in which is in my mind, because the primary central nervous system tumor are graded based on the tumor tissue analysis and performed by the neuropathologist. So the pineal region tumor are grouped into four grades and subtype, or the subtype and the subtype based on their characteristic. So the grades, it's called grade 1, grade 2, grade 3, and grade 4, and also written in the Roman 1, 2, 3, and 4. But you know that the grade 1 pineocytoma are the low grade tumor, and it means that the tumor cell grows very slowly or normally, not we said or subnormally. Or and the grade 2 or 3 pineal parenchymal papillary tumor of the pineal region are both the mid-grade tumor, and this means they have a higher chance of coming back after being removed. So and the grade 4, which is the pineoblastoma, are the malignant cancerous cell. This means they are the fast growing and tends to invade nearby tissue, and that cause the big problem for the patient and the other. So here, or we can say like that, the pineal region tumor are generally classified as pineal parenchymal tumors, germ cell tumors, adjacent cell tumors, astrocytes, aragonite, cap cells, or metastasis. So here I want to mention like that the histopathology is telling that pineocytoma comprise of the small cell similar in appearance to the normal pinealocytes and arranged in sheet, and the pineocytoma or the pseudo rosettas are characteristic and not seen in the healthy pineal gland tissue. So the pineocytoma do not have a well-formed blood vessel barrier, blood-brain barrier, and such enhance vividly with contrast. So this we can say the synaptophysium, or the positive neurofilament protein, or the positive neurospecific analoids, or positive other neuronal marker such as the tau protein, or the or we can say the chromogranin A, or the we can say the neuronal nuclei are negative. So these kind of the histopathological findings are suggestive for the pineocytoma. Pineal parenchymal tumor with the intermediate differentiation characteristically show two distinct microscopic features, and the lobulated pattern shows poorly defined lobules and separated from each other by large fibrous vessel, and the diffuse pattern is the reminiscent of the oligodendroglioma or central neurocytoma, with the large pineocytoma rosette characteristic of the pineocytoma not evident. And this, and we can say the synaptophysium positive and the neurofilament protein is positive, and the variable neuronal nuclei is negative. In the third form, which is the papillary tumor of the pineal region, demonstrate the variable morphology from the solid to the predominant papillary or reminiscent of the ependymoma, include the evidence of the ependymal rosette area of the necrosis are sometime present, cytokeratin, or we can say AE1 oblique 1 or a CAM 5. So these are the positive S100 protein or positive vimentin, positive we can say the transthyretin, or the positive neuron specific annulase, or positive microtubule associated with protein 2, or positive glial fibrillary acidic protein with variable. So the pineoblastoma tightly packed cells around the cell and a high nuclear to the cytoplasmic ratio, and the Homer-right rosette and the we can say the Flexner Winterstein rosette are occasionally seen, and the areas of necrosis are frequently encountered. So the mitotic rate is usually high, and synaptophysium positive, or we can say the neuronal markers such as the neuron specific annulase or the neurofilament protein, or we can say the chromogranin A is different. So here the germinomas originate from the we can say the primordial germ cell, similar to those in the gonadal germinomas, and cells have large nuclei with prominent nuclei, and the lymphocytic we can say the infiltration is common on immunohistochemistry, and they stain for the placental alkaline phosphatase, and the CSF sample can show placental alkaline phosphatase and beta HCG. Uh, I want to present here few things such as the clinical history and physical. If we want to go, then the clinical presentation for all tumor of the pineal region are secondary to the obstructive hydrocephalus and the compression of the tectum. So that regardless of the pathology, the physical exam finding will similar for all of the tumor, and the hydrocephalus, the headache, nausea, failure to thrive, or we can say the macrocephaly, blurry vision, sleepiness, drowsiness, or coma are there. But exam, as you know, the Cushing's triad, hypertension, bradycardia, and irregular respiration, or the bilateral optic nerve swelling, or the bilateral sixth nerve palsy are important here. So the compression of the tectum, for example, Parenchymal syndrome, and the history difficulty walking upstairs or diplopia. So the history, headache, nausea, failure to thrive, or macrocephaly, and definitely blurry vision, sleepiness, or drowsiness, or coma because of the hydrocephalus, and it is very very much obvious, but definitely important to understand. Here, for maybe everybody knows headache, nausea, failure to thrive, and the macrocephaly is not a big deal. We can understand, but definitely we have to understand the blurry vision, sleepiness, drowsiness, or coma. And the exam here, the Cushing triad, hypertension, bradycardia, and irregular respiration, and then the bilateral optic nerve swelling, and the bilateral sixth nerve palsy, and then the compression of the tectum, such as the Parenchymal syndrome. So here the history, difficulty walking upstairs or diplopia, and the paralysis of upgrade gaze and the conjugate downward gaze. So the comparison of the vertical gaze center at the rostral interstitial nuclei of the medial longitudinal fasciculus. This is we have to understand when their compression of tectum is coming, then we have to talk about the Parenchymal syndrome, and Parenchymal syndrome definitely showing that there is a walking upstairs difficulty, and the diplopia is important very much. But as I mentioned before, there when we were examined regarding the hydrocephalus, then the Cushing triad was very important. There's a hypertension, bradycardia, and irregular respiration, and bilateral optic nerve swelling, and bilateral sixth nerve palsy that was there. And here in Parenchymal syndrome, we have to understand there the paralysis of upward gaze and conjugated downward gaze, and compression of the vertical gaze center at the rostral interstitial nuclei of the medial longitudinal fasciculus, and the light near dissociation and compression of the pretectal nuclei in the superior colliculus. So the convergence retraction, nystagmus, and eyelid retraction, which is sign, the Collier sign, because the convergence retraction, nystagmus, and eyelid retraction is the Collier sign, and these sign or these triads or these syndromes we have to remember, and damage to the supranuclear fiber of the third nerve at the posterior midbrain, it will be compression of the tectum, and which is called the Parenchymal syndrome. And the evaluation like such as the serum tumor marker are indicated when specific tumor are suspected, and include alpha fetoprotein, beta HCG, and the placental alkaline phosphatase, and the CSF analysis, which can be obtained by the lumbar puncture if there is no hydrocephalus, or during endoscopy is useful for most tumors. Imaging, you remember the brain magnetic resonance imaging with and without gadolinium enhancement is the gold standard of evaluation for the pineal region tumor. However, if not available, had computed tomographic scan or angiography and ultrasound in infant play a very important role. Normal finding on the neuroimaging of the pineal gland, such as the CT scan, calcification is typical in the adult pineal gland. In children under the age of the 5 year, calcification is not present, and calcification of the spinal gland reaches a plateau at about 30 years of the age. And the MRI, which is the gland, is similar to the intensity of the gray matter, and appear is a small nodule of the tissue in the posterior aspect of the third ventricle, and it vividly enhancing with the gadolinium due to the being outside the we can say the blood-brain barrier, and calcification are often seen. So the tumor markers are also important, as I mentioned, alpha fetoprotein, beta HCG, and the placental alkaline phosphatase, as I mentioned before. Then the CSF analysis is very, very important if there is no hydrocephalus, and so it is very important to know or evaluate the problem. And the imaging, definitely the brain magnetic resonance imaging without gadolinium is gold standard considered, and because if it is not available, then you have to go for the computerized tomography or the angiography or the ultrasound in infant. But the normal finding on neuroimaging on the pineal gland CT scan, calcification is typically in adult pineal gland, and in children under the age of the 5 year, calcification is not present. So the calcification of the pineal gland reach a plateau of about 30 years of the age. So if no calcification, you cannot say there is no tumor, because in children there is no calcification. But if we consider the MRI, the gland is similar to the intensity of the gray matter and appear as a small nodule of the tissue in the posterior aspect of the third ventricle, and it is vividly or avidly enhancing with the gadolinium due to the being outside the blood-brain barrier, and calcification are often seen. So the MRI brain will show homogeneous enhancing, except those presenting with the heterogeneous cellularity, and the dense tumor like the pineoblastoma and the germinoma will have the restricted diffusion on the diffusion weighted image. On the other hand, pineal cysts are non-enhancing and usually have thin wall, therefore a thick wall exclude a cyst So so the calcification are often present and easier to identify in the head CT scan and can sometimes point in the, we can say, the right direction of the diagnosis. And the pineal parenchymal tumors such as the pineocytoma, pineoblastoma tend to be the peripherally and disappear or calcification, whereas the germ cell tumor tend to engulf the calcification. An easy way to remember this is that pineoblastoma tend to blast the calcification apart. Many tumors of the pineal region may cause local and distant seeding, and thus full spine MRI may be considered as a part of initial evaluation. Local invasion and remote seeding are significant for prognosis and may change initial management and adjuvant therapy drastically. Findings that can point to worse prognosis include the local invasion, so the CSF seeding and extensive and a peritumor edema here, and the local invasion can be seen in pineoblastoma and most germ cell tumor. The CSF seeding can be seen in the pineoblastoma, and the distal seeding is most common, and in germ cell, proximal seeding is most common. It is definitely is not sometimes easy to remember, but you can try to remember when we are going for the pineoblastoma, then definitely you are suspecting pineal, then the distal seeding are most common, and when you are considering germinoma, then the proximal seeding is more common, and this local invasion can be seen in both germ cell tumors such as the germinoma and the pineoblastoma. Treatment regarding before that I want to show one MRI to you if possible for me. Actually, I want to see how the MRI shows. As I told you, vividly enhanced, so you can appreciate here. Yes, this is here. This is vividly enhancing, and here you can appreciate it also vividly enhancing in picture A. And picture A is the axial image of the MRI, which is post contrast, and you can see it vividly enhanced. And in the sagittal view, then definitely you can appreciate vividly enhanced. In the coronal view, you can appreciate the vividly enhanced. And if you go with the T2 weighted image, this is the T2 weighted image, and it is showing the hyper intensity in that area, and you can see that this is the hyper intensity in this area. And here if you see the hyper intense in the T1 weighted image, and in here down you can appreciate there is a iso intense, or we can say somehow iso intense or hypo intense in this area. So now you can appreciate how the MRI behaving in all three different kind of images. And why I chose this picture? I chose this picture because I was thinking it's showing the CT scan, and it is a contrast CT scan on the image A, and the image B, there is a T2 weighted image of MRI. Both are the axial views, and you can see how the enhancement it took in the CT scan, and you can appreciate the hyperintensity in the T2 weighted image of the MRI. If you see this picture, you can appreciate the T1 weighted definitely contrast image, and it is how this is the MRI, both axial and sagittal A and B, which is very much clearing in front of you how they are behaving. And so you can see how the tumor is behaving here, and this is a pineal tumor, and this is the third ventricle in front of it, and the superior cerebellar cistern behind of this, and then laterally you can see the thalami, and so this is here you can appreciate this is the superior sagittal sinus, and this is the posteriorly you can see this is the internal cerebral vein. This is the internal cerebral vein superior to this, and then the vein of Galen here. This is the vein of the Galen posteriorly or superiorly, and the velum interpositum or stria medullaris, that area is suggestive for a lot of knowledge or a lot of anatomy here. And this MRI is why people are telling this the choice or the golden choice here. Now I want to come for the treatment and the management here. I want to talk about little for this because imperative to follow treatment algorithm to ensure adequate diagnosis and the treatment. And if hydrocephalus absent, so the tumor marker obtains in a serum and the CSF. So if positive, then treatment based on the most likely pathology, and if negative tissue diagnosis is necessary, then the biopsy, stereotactic, endoscopic is open, and the resection based on the preliminary radiographic finding or pathological finding. So the final management is based on the pathology, and as you know, if positive treatment based on most likely pathology, and if negative tissue diagnosis is necessary, then the biopsy, stereotactic, endoscopic, open. These all are very important, and the part of the treatment, and the resection based on the preliminary radiograph finding or pathological finding. So the final management is based on the pathology, and if the hydrocephalus present CSF fluid diversion, best opinion is an endoscopic third ventriculostomy, and always attempt endoscopic biopsy during, for example, we can say the like the ETV or the endoscopic third ventriculostomy, and the final management is based on the pathology. Endoscopic third ventriculostomy is performed by the fenestration of the floor of the third ventricle, and thus forming a passage between the third ventricle and the prepontine cistern. And in most cases, right frontal burr hole just anterior to the Cocker's point is performed, and the neuroendoscope is advanced until the ipsilateral lateral ventricle is reached, though the ipsilateral foramen of Monro and the floor of the third ventricle and a tuber cinerum is fenestrated and expand to permit adequate CSF flow. The biopsy is obtained from the posterior aspect of the third ventricle, and if endoscopic third ventriculostomy fails, the definitive treatment is a ventricular shunt placement, and the ETV success score was there are three variable for it. We can say the calculation: age, cause of the hydrocephalus, and we say the previous ventricular shunt placement. To calculate the success, or we can say the score, one must add up to the percentage of the success or each variable. The lowest score is 0 and the highest is the 90%. So age here, I want to tell you here, then the 1 month ETV, when a success score if less than age 1 month. I want to repeat this phrase because it is very important to understand, in my humble opinion, and this learning curve like that. Okay, I know that the endoscopic third ventriculostomy can do lot of things, such as it performed by fenestration of the floor of the third ventricle and thus forming a passage between the third ventricle and prepontine cistern. It will make a fenestration between the prepontine cistern and the third ventricle. But in most cases, the right frontal burr hole, just the anterior to the Cocker's point, is performed, and the neuroendoscope is advanced until the ipsilateral ventricle is reached. So though the ipsilateral foramen of Monro and the floor of the third ventricle tuber cinerum is fenestrated and expanded to permit the adequate CSF flow. This is the ipsilateral foramen of Monro, and the floor of the third ventricle tubal cinerum is important for the fenestration. And the Cocker's point anterior to the, we can say is performed. The neuroendoscope is advanced until the ipsilateral lateral ventricle is reached, and then you have to find the ipsilateral foramen of Monro, and then you have to go to the floor of the third ventricle there near the tuber cinerum, and then you have to fenestrate and expand it to the it will permit the CSF flow easily, and you can see the flow. And you can appreciate on that endoscope, you can easily see it is not a difficult to understand. And the biopsy you can take from the posterior aspect of the third ventricle, and if endoscope third ventriculostomy fail, then definite treatment is the ventriculoperitoneal shunt. And you know that the endoscopic third ventriculostomy success score and uses 3 variables for its calculation, and the age, cause of hydrocephalus, and the precious ventricular shunt placement to calculate the success score. And one must add up the percentage of the success for each variable, and the lowest score is 0 and the highest score is the 90%. Age here I will tell you how. If less than 1 month, then the score is 0, means the success rate is very low or 0. In 1 to 6 months, then success rate is 10%. If 6 months to 1 year, then success rate is 30%. And if 1 to 10 year, then success rate is 1 year to 10 year, then success rate is 40%. And when more than 10 year, the success rate is 50%. So cause of here we have to understand according to age we have to choose, and if we want to choose in a very young age, and even though 6 months to 1 year, they're only 30%. Yeah, but after 1 year, any age is a 40%, and after 10 years, any age is 50%. So the cause of the hydrocephalus post-infectious means if the post-infectious, then 0%. It's post-infectious, success rate 0%. Means it's infectious, not indicated, no value for that. And when you go for the myelomeningocele or interventricular hemorrhage and the no tactile tumor, then 20%. If they are the no tactile tumor or interventricular hemorrhage or the myelomeningocele, then 20%. But they are the tactile tumor and the equiductal stenosis or other, then the 30%. So in the same way, if the previous ventricular shunt placement, if you previously presented ventricular shunt, then 0%, and then if you didn't put the shunt, it is a 10%. So definite treatment is based on the pathology. So the surgical resection here important, and all pineal parenchymal tumors, mature teratomas, residual tumors after chemotherapy, radiotherapy, which is called the second look surgery. So this is the radiotherapy. You know the second look surgery is called the residual tumor after chemotherapy, and the radiotherapy reserved for the patient more than 3-year-old, especially in the germinoma. If they are the germinoma, then the radiotherapy is good. And the chemotherapy plus radiotherapy is alone, or the chemotherapy alone, if the less than 3-year-old, then the adjuvant chemotherapy plus radiotherapy are given to all tumor except pineocytoma and mature teratoma. If complete resection is achieved, then no need. So then what I'm telling, and that all non-germinomatous germ cell tumor, they need definitely, and the germinomatous germ cell tumor, if less than 3-year-old, you can give. Surgical approach to the pineal gland is chosen based on the specific location of pathology and surgeon preference. You know the paramedian, infratentorial, supracerebellar resection useful for all pineal region tumor except for the large tumor that extend laterally and inferiorly, and the left-sided suboccipital craniotomy is performed to protect the trochlea and often more dominant right-sided vein, or we can say the dural sinus include the transverse sinus. Most flexible approach for the resection of the most spinal for the pineal range tumor is the paramedian, infratentorial, supracerebellar resection. But other options, we have the midline, infratentorial, we can say the supracerebral resection, and they are traditionally used for exposing the pineal region tumor and performed via bilateral midline suboccipital craniotomy. And then the limitation of this approach include the limited lateral or inferior visualization caused by the angle of the tentorium and the obstructive apex of the culmen, and respectively. Almost all midline bridging vermin veins are invariable sacrifice, and the occipital transtentorial resection. Occipital transtentorial resection is an other option. Occipital transtentorial resection is particularly useful for the large pineal region tumor and that extend laterally and inferiorly performed through the unilateral occipital craniotomy. A limitation of this approach include the difficulty with anatomic orientation to need to devoid the tentorium and possibility of the homogeneous or heminopia from the occipital lobe retraction. It is crucial to screen the full neuroaxis with all pineal region tumors. The prognosis and the treatment dramatically vary and depending on the CSF spread of the tumor and the extent of the CSF seeding and the drop mats and have a poor prognosis. So MRI of brain, cervical, thoracic and the lumbar spine with and without contrast is required to adequate screening of the neuroaxis and the spinal radiotherapy as a prophylactic treatment is also controversial in my humble opinion. No need to unnecessary radiation until we have some evidence based. Differential diagnosis here, the cystic non-neoplastic lesions such as the pineal cyst or the cavum villi interpositum, or we can say the arachnoid cyst. These three are pineal cyst, arachnoid cyst, and the cavum villi interpositum. And when the pineal parenchymal tumor, the pineocytoma, pineal parenchymal tumor with intermediate differentiation, pineoblastoma, papillary tumor of the pineal region, and the germ cell tumor such as the pineal germinoma, embryonal carcinoma, choriocarcinoma, teratoma, mature, immature, yolk sac tumor, these all are very important also to understand when we are talking about the pineal parenchymal tumor, then the pineocytoma, pineal parenchymal tumor with intermediate differentiation, pineoblastoma, papillary tumor of the pineal region, and these are coming in the WHO 2 and 3. But pineocytoma considered WHO 1. But a germ cell tumor, it is really a need to understand pineal germinoma, embryonal carcinoma, choriocarcinoma, yolk cell tumor, teratoma, mature or immature. And tumor also encountered with the pineal region, which is maybe astrocytoma, maybe meningioma, and the cerebellar metastasis. So pineal gland metastasis also there, and the vascular region cannot be denied. Vein of Galen aneurysm malformation, it is just behind or posterior to the pineal gland, and internal cerebral vein thrombosis. So the prognosis, it depends upon the tumor's kind or tumor's classification. You know that the pineocytoma relatively good prognosis, and if treated surgically, they have an excellent prognosis when complete resection is achieved, and which is the most of the time they are well circumscribed lesions, and the 5-year survival of 86 to 91% and local recurrent and even CSF metastasis are very, very rare in pineocytoma WHO grade 1. Or we can say the well differentiated, or we can say the modified. Other one is a pineal parenchymal tumor with the intermediate differentiation. We can say the prognosis is between of the pineocytoma and the pineoblastoma, and they are more likely to present with the localized disease, and the median overall survival of 165 month versus 77 month of pineoblastoma, with the median progression free survival of 93 month versus 46 month for pineoblastoma. Pineoblastoma, it is the most aggressive of the pineal parenchymal tumor, and the median overall survival reaching 4 to 8 years, and the 5-year overall survival rate vary from 10 to 81%, and prognosis is negatively affected based on the dissemination of disease at the time of the diagnosis and young patient age and the partial surgical resection. So the chemotherapy treatment and the possible addition of the stem cell can provide a better outcome. Pineoblastoma, as I mentioned, it is aggressive tumor and the pineal parenchymal tumor, and the median overall survival time reaching from 4 to 8 years, and the 5-year survival rate vary from 10 to 81%, and prognosis negatively affected based on the dissemination disease at the time of the diagnosis and the young patient age and the partial surgical resection. So the chemotherapy and the possible addition of the stem cell can provide a better outcome, but how much is still it is under research. Papillary tumor of the pineal region, local recurrence often affect prognosis, and the 5-year overall progression-free survival rate 73% and 27% respectively. So the gross total resection and the younger patient age are associated with improved overall survival, and radiotherapy and chemotherapy had no significant impact, and the screening of the entire neural axis is required as CSF dissemination occurs in up to 7% of the cases. Papillary tumor of the pineal region, local recurrence often affect prognosis, and the 5-year overall and the progression free survival rate were 73 to 27% respectively, and gross total resection and the younger patient age are associated with improved overall survival. Radiotherapy and chemotherapy had no significant impact. And screening of the entire neural axis is required in the papillary tumor of the spinal region, so the pineal region and spinal area. And dissemination up to the 7% of the cases. Germinoma remarkably radiosensitive and with long-term survival rate of more than 90% after craniospinal radiation, and the addition of the chemotherapy to treatment regime may provide comparable tumor control at lower radiation dose and the field voluminous. And the leptomeningeal or the interventricular spread is not uncommon at the time of the diagnosis, occurring in 13%. Mature teratoma curable by the complete surgical excision, and the immature teratoma along with the germinoma occupying an intermediate position in terms of the biological behavior, and the size and the location determine prognosis. Embryonal carcinoma or choriocarcinoma or yolk sac tumor, endodermal sinus, these are the most aggressive germ cell tumor, and the survival rate as high as 60 to 70% and can be achieved with the combined chemotherapy and the irradiation, and the local recurrence and the CSF dissemination are the usual pattern of the progression. Embryonal carcinoma, choriocarcinoma, yolk cell tumor, endodermal sinus, they are the most commonly aggressive germ cell tumor, and the survival rate as high as 60 to 70% and can be achieved with the combined chemotherapy and irradiation, and the local recurrence and the CSF dissemination are the usual pattern of the progression. And the complication here, the tumor can lead to the, we can say, the various complications, hypothalamic or the endocrine dysfunction, or we can say the extraocular movement dysfunction, hemorrhage, venous infarct, seizures, hemiparesis, ataxia. And the following consultation should be obtained, appropriately diagnose and treat the tumor, where the neurosurgeon, neurologist, pediatrician, endocrinologist, ophthalmologist, hemato-oncologist, and the radiation oncologist all are very, very important and mandatory here, and any of these tumor can recover even after the long period. Therefore, the prolonged follow-up of the patient is unnecessary. So those patients with the cerebral shunt also need lifelong evaluation, as the prognosis and the treatment are depend on the histology, and the patient and the parent need to be counseled about their particular tumor and the requirement of the adjuvant therapies. So here definitely a good team definitely give the good results, and you can find a better outcome as compared to the simple. But here I want to present as a small scale for the analogy. An 8-year-old girl was referred by the pediatrician for concern of rapid development. After referral to the endocrinologist, a preliminary diagnosis of a precocious puberty was made, and MRI revealed a hydrocephalus and a lesion in the pineal region, and she has also been noted to be clumsy at school lately, and the mom described her daughter as if off balance, and initially assessment shows the child, who appears older than her in a stated age and neurological neurological examination reveal the mild cerebellar dysmetria, or we can say the difficulty with the rapid alternating movement. And here the differential diagnosis come with the hydrocephalus, pineal cyst, lipoma, epidermoid, vascular malformation, pineal region tumor include the germ cell tumor, glioma, meningioma, metastasis. And here we and here and definitely we can appreciate. I want to mention here, this is the pictorial from the but it was somehow like that. You can appreciate there the T1 and T2 weighted images, and it is showing there the tumor in the pineal region. Yes, I did the CT scan and demonstrate the hydrocephalus and the calcification, but will not further assist in the differential diagnosis, but may suggest a germ cell tumor if mass is iso or hypointense relative to the gray matter on the T1 weighted image and iso to the hyperintense or T2 weighted image. So the contrast image of the germ cell tumor demonstrate enhancement and sometimes cystic component which do not enhance. The teratoma may be characterized by the heterogeneity on T1 and hyperintensity on T2 weighted image. So the teratoma may also be calcified, and the pineal gland tumor such as the pineocytoma or the pineoblastoma can be differentiated on T2 weighted image. So the pineoblastoma has an isointense signal on T2 weighted image and demonstrate the brain invasion and edema. So the pineocytoma have a hyperintense signal on T2 weighted image, and the pineal cysts are round and smoothly demarcated on MRI and appear similar to the CSF with occasional ring enhancement. Further workup required definitely, and as I mentioned, the MRI may suggest a germ cell tumor if the mass is iso or hypointense relative to the gray matter, and the T1 weighted image and the iso to hyperintense on T2 weighted image. That contrast image of the germ cell tumor demonstrate enhanced and sometimes cystic component and which do not enhance. And then teratoma may be characterized by the heterogeneity on T1 and hyperintensity on T2 weighted image. So the teratoma may also calcified, and pineal gland tumor such as the pineocytoma and pineoblastoma can be differentiated on T2 weighted image. So the pineoblastoma has an iso-intense signal on T2 weighted image and demonstrate the brain invasion and edema, and the pineocytoma have a hyperintense signal on T2 weighted image. So the pineal cysts are round, smoothly demarcated on MRI and appear similar to the CSF with occasional rim enhancement. Further workup measurement of the germ cell marker, beta human chorionic gonadotropin hormone and alpha fetoprotein in CSF and serum should be obtained in all patients, and almost most pineal region tumor are not marker producing, and their presence indicate a malignant germ cell tumor in the setting of the elevated germ cell marker. A tissue diagnosis is not necessary, and most center and proceed with the chemotherapy and the radiation therapy after therapy germ cell marker, and can also be used to assess the effectiveness of treatment and follow to the monitor potential recurrence in the absence of positive serum or CSF marker. A tissue sample is required, and CSF cytology is useful as the pineal blastoma and the germ cell tumor have a propensity to seed the CSF. As you know, the pineoblastoma usually and proximally and it will seeding, and that germ cell tumor and proceeding that downward like the germinomas. Pineal region mass include the simple cyst and the germ cell tumor, and a tumor arising from the cell in the spinal gland itself. So the pineoblastoma and the pineocytomas, and the pineocytoma is a slow growing grade 2 tumor, and the pineoblastoma is a more aggressive grade 4 malignant tumor, and there is also grade 3 intermediate form which is called the pineal and tumor, present only 1% of the all brain tumor. However, they account for 3 to 8% of all cranial tumor in the pediatric age group. So the pineal tumor can cause the hydrocephalus, and they're directly related to the function of the pineal gland and endocrine syndrome, which arise from the secretion of the hormone by germ cell tumor, and the pseudoprecious puberty and initiated by the beta HCG can be observed with the germ cell tumor in either the pineal or the suprasellar region. So the treatment of the option or the clearance of the or the clearance Here, treatment option: clearance of the obstructive hydrocephalus from the pineal mass must be performed, and the commonly before the removal of the pineal tumor, the endoscopic third ventriculostomy and the biopsy of the tumor performed in one operative procedure is ideal, especially as it prevents potential for the peritoneal seeding, and the benign pineal tumor include the mature teratoma can be cured with the surgery alone, and radiation is the primary curative treatment of pure germinomas arising intracranially and is beneficial for the many malignant germs and parenchymal tumors that are not completely resectable, and the pineal blastomas and the germ cell tumor include the germinomas with positive cytology are usually treated with craniospinal radiotherapy, and which generally follows chemotherapy. So the mature teratoma and the benign teratoma or the cysts are not treated with the radiation. So the malignant tumor exception, such as the germinomas, will benefit from the total resection followed by the chemotherapy and irradiation, especially if significant brainstem compression is evident. Here, definitely we can talk a lot more about this pathophysiology or other which we already talked. But I want to here present a little bit the surgical technique, which is I think very important. In pineal region can harbor lesion and that exhibit to the wide range of the anatomical extension. So the mass can be below the tentorial apex and the midline and extend below and above the tentorium laterally in the either direction, or can be mostly encased within the posterior third ventricle, and the surgical approach should be tailored to each patient with consideration given to the tumor size and the extension advantages and the disadvantages of each approach and surgeon's familiarity. In infratentorial supracerebellar approach performed in the sitting, prone with the neck flex and the concorde position provide a good corridor to the pineal region for the mass that are midline and below the tentorial apex. Furthermore, the lesion is encountered first, even the deep venous system is displayed superiorly and best for the small midline lesion. And the supratentorial occipital transtentorial approach it's best when the lesion has a significant extension below the tentorium, or laterally it can also be used when the trochlea is low lying. So the precluding the infratentorial supracerebellar approach, and this approach provides the most extensive view of the pineal region, and the tumor extended even the cerebello and mesencephalic cistern can be assessed. And this approach is also found in the 3/4 prone position to provide the gravity retraction to the non-dominant hemisphere for assistance with the development of the parafalcine corridor. And the posterior transcallosal approach is another option, particularly useful if the splenium is divided by the tumor. So it is depend upon the location, and it is depend upon the location. And I want to show the picture. Definitely you see multiple times, but this picture is very important to understand how we are approaching from behind when we are going supratentorial and suboccipital supratentorial approach, or we are going for the suboccipital infratentorial approach or transtentorial approach, or the people are going also endoscopically and with the help of the image guided system. Endoscopic without image guided is questionable, but in my experience an image guided system is mandatory for the endoscopic approach. And when you are doing the endoscopic resection, definitely it's a magic, in my humble opinion. There the endoscope creates the magic, and if you are going through the endoscope and removing the tumor, actually you are creating the magic, and the less morbid and the small craniotomy you can do a magic. But definitely you have the tools and you have the expertise for that, and the good learning curve, this all required for this. I think we have to understand this. There you can see there the cut and precentral vein, and then behind the remnant of the aragonite, then you can see there the tentorial edge or on the both sides, and you can see the basilar vein of the Rosenthal, and then you can see the tumor. It is not easy microscopically. It is definitely it is very deep, and definitely the light is not giving you the as you are thinking, but definitely the endoscope give the, because the and now the angled endoscopes are available, and these angled endoscope are very, very important. So the basal vein of the Rosenthal, thalamus, and tentorium, choroid plexus. Here you can appreciate when I am making up, and you can appreciate here. This is a very good picture to understand the surgery or the and you can see the both thalami. As I am telling, the anatomy is very important. If you know the good anatomy, definitely you can perform either endoscopically with image guided system, or you go with the help of the open by the open craniotomy. Then you can do something good for the patient. And here you can appreciate the choroid plexus in the middle. Then you can appreciate the tentorium here. Then you know where the cerebellum, and you in the third ventricle, the thalami you should know, and the vein and the basal vein of the Rosenthal you should know. This picture also very informative in my humble opinion. If you can see this, you can appreciate there the corpus callosum, and you can appreciate the internal cerebral vein, and behind that there the pineal gland, or then you can see the basal vein of the Rosenthal, and then you can see there the incision in the tentorium and the incision in the falx cerebri. You can give the incision of the falx cerebri here if the tumor extension is there, and if you can give the transtentorial incision if you want to give there, and the vein of Galen, definitely you have to retract from the side, because you don't want to injure that, and that may create a big problem, and for that, and the surgery will be definitely is not means worthwhile. But if you see in the down, when you in the circular, when you are seeing with the microscopically, you can appreciate the internal cerebral vein, and then when above that there's the corpus callosum, and then you can see the vein of the basal vein of the Rosenthal. It's very important to understand here. It is with the vein of the Galen, and the straight sinus, and the precentral cerebellar vein, and the tentorium, and the tumor, all are very, very important to understand.